Okay, so hello and welcome back. So today we'll be discussing the histological considerations in the diagnosis of glomerulonephritis. Specifically, we'll talking about the changes that occur in the histological entities that correlate clinically with the development of nephrotic syndrome. And this will be part 3.1 in an approach to peripheral edema. So before we go ahead, we need to understand the normal anatomy. So this is the glomerular cut section. Actually, this is specifically a cut section to us through one single capillary within the glomerulus. Okay, you can see that this orange structure, that is your endothelium. Okay, and the white cells here, these are your podocytes or the visceral podocytes. Your this green, your yellow cell here is meant to be a an inflammatory cell, either a mononuclear cell, or I'm not drawn the nucleus like that, but maybe even a neutrophil. And this blue cell here, that is your mesangial cell. Okay, so these are your, this is the normal anatomy that we describe. The red line here represents the glomerular basement membrane. Okay. Now, however, this is easy to understand. This schematic is easy to understand the mechanisms behind the various forms of glomerular inflammation and glomerular nephropathies. However, it's not really what you see under the microscope. So, what do we see under the microscope? What we see is, at least schematically, this. Okay. So, what I've done is I've just taken one of these capillary cut sections, and I've shown you how it looks when you should see it under the microscope. So these capillary cut sections together form with three or four, tufts that you can see separately here. There is a the red vessel here, that is your afferent arteriole. The blue vessel here is your efferent arteriole. It's still an arteriole because that blood is going to obviously get shunted around the tubules again as the vasa recta. Okay. Then this is your Bowman space. Bowman space. Okay. And these two together form the hilum. So right opposite the hilum, we have the origin of the proximal convoluted tubule, and these are the structures that you see in a normal glomerulus. So this is a more anatomically intuitive schematic for your normal glomerulus. However, obviously there is not the actual thing that you see. So this is what you see in reality. Okay, so the white space here, that is your Bowman space. Okay, you got a hilum here. You got your, the hilum located right here. This is the hilum. Okay, then you've got the origin of the proximal convoluted tubule. Now, importantly, the glomerulus is a three-dimensional structure, and we're taking a two-dimensional cut through it. So, in many, or rather most cut sections through the glomerulus, you will not see both the hilum and the proximal convoluted tubule. But we'll see, in order to classify the different forms of FSGS, it is important to at least find one of these glomeruli, which, if you look hard enough, often you can find one. Okay. And the efferent arteriole that is entering here is actually divided into different tufts. So approximately this would be one single tuft. Okay. And here is another, and here is another. So like I said, three separate tufts are there. And within the tufts, you can see that there are open capillaries with RBCs within them. Okay, those red cells there are RBCs. So this is what you see under the microscope. So this is the actual histomorphological appearance of a glomerulus. Okay, so now having gotten that out of the way, what we'll be discussing today is we'll try to derive the histological morphology of the three types of histological entities that clinically result in nephrotic syndrome. Then we'll talk about, we'll learn to identify the histological morphology of membranous glomerulonephropathy. We'll learn to identify the histomorphology of minimal change disease, and then we'll learn to identify the histomorphology of focal segmental glomerular sclerosis. And in that, we've already discussed in the previous discussion how the collapsing variant is actually different from the other variants of FSGS. So we'll understand what that entails in terms of how it looks like under the microscope. Then finally, or rather, we'll try to understand the physical constraints that result in the perihilar variant of FSGS, and how that results in a clinically poorer prognosis. And we learn to identify the perihilar versus the hypercellular versus the tip variants of FSGS. So starting off with glomerulonephritis, the histological correlates of a nephrotic syndrome, that is membranous glomerulopathy. So again, that is what I have, the schematic that I just shown you. So now, how is this different from the histomorphology of the normal glomerulus that we saw? You can see that actually I can almost trace out the basement membrane here, but in the other image I couldn't really do that. Okay, so the basement membrane is very thickened. Okay, and we discussed already how membranous GN is due to, a subepithelial deposition of antigen antibody complexes, and then how that results in changes that we've discussed in detail. So this is the expected morphology. In light microscopy, you don't always, see something so obviously showing a thickened capillary basement membrane, but you might. Okay, so as you can see now. Uh, Let's get rid of these. Okay, so as compared to your normal glomerulus, this is your normal. There is definite thickening of the glomerular basement membrane. But like I said, this is not something that you can put your hat on always. So sometimes you may find it, sometimes you may not have it. So what do we do? Okay, so what we can do is we can go ahead and find a, yeah, objective way of doing this. So how do we do it objectively? One is we can stain the basement membrane itself. Okay, so there are some specific stains, methenamine stains that has contain silver in it. So they call silver methenamine stains, and they basically go and get absorbed onto the collagen that is present within the basement membrane, and as a result they highlight the basement membrane. But if you look carefully, what you find is not only is it is the basement membrane very, very thickened, there is also something very interesting there. Okay, look at the basement membrane in this area. There appear to be spikes here, like this. Okay, and those spikes, they look like the bristles of a comb. So those spikes are because the podocyte and the basement membrane, in between that, there is the deposition of your immune complexes. And then what happens is that the podocyte deposits more basement membrane. So the basement membrane forms in between these two deposits. So there's a deposit here, then there is the thickened basement membrane, then there is a deposit. So this, when you stain the basement membrane with your silver stains, that shows a spiky pattern. So I hope that is clear. Now the other thing I can do is I can stain with immunohistochemistry, because those deposits in between the spikes are immunoglobulin. So if I use immunohistochemical staining, I will see this kind of linear staining involving the basement membrane. So this is to be expected. Okay. Then finally, okay, I've already answered the question. So what are we targeting? What antigens? We've discussed in great detail what those antigens might be. In primary, most commonly, obviously, it is your Plato receptor and your thrombospondin, domain like 178. But we've discussed that that's an extensive topic in itself. Okay. Now, in immunohistochemistry, what you find is that there is this kind of staining for subepithelial deposits. And again, it's showing see, I wouldn't call this linear per se, okay, but you can clearly see that it is following the contours of the basement membrane. However, see, this is not called linear. Linear is some very specific for another entity which causes glomerulonephritis with nephritic syndrome. That is your glomerular basement membrane staining in your Goodpasture syndrome, and we'll come to that in a subsequent lecture. Okay, so there's still granular but contiguous staining. Okay, okay, so this is granular. Now, going on to the second entity, that is minimal change disease. So in minimal change disease, you find nothing. There is minimal change. So there's nothing there. It's completely normal. Okay. So how do I say it is minimal change? Usually biopsy is not performed for minimal change disease. Uh, but if you really do have a patient with minimal change disease, especially adult minimal change disease, it is prudent to actually get a electron microscopic one. Although in more normal clinical practice, we don't normally do it. Okay, so I will leave it at that. Basically, all of these entities on electron microscopy will show podocyte effacement, because the pathology is primarily affecting the podocyte. Okay, now coming to the interesting part of the discussion, that is your focal segmental glomerulosclerosis. Yeah. So what about our terminology in case of FSGS? So here we've got FSGS. Okay. Most textbooks and indeed most discussions on the topic actually tend to focus mostly on the FS part of it. Okay, that is the focal length segmental part of it. However, actually we need to go beyond that. But we'll see what focal and segmental mean first, and then we'll go ahead and discuss the others. So if this is a glomerulus, uh, and then say 10 such glomeruli. Okay, if less than 50% of those glomeruli, that is less than 5%, 5 out of those 10 glomeruli are affected by the pathology, then the disease is called focal. Okay, it is focal essentially on scanning electron microscopy. And segmental is easy to recall because S in segmental stands for a segment. Now, if you were to think of your glomerulus as a sphere, which it actually is, okay, the entire it would be a globe. So if the entire thing was affected, we would call it global. Okay, but however, if less than 50% of the pathology of the glomerulus was affected, then we would call it segmental. So essentially, what we mean by focal and segmental is that less than 50% of the glomeruli are affected, and less than 50% of the area of the glomeruli that are being described are affected. Okay. Now, what does glomerular sclerosis mean? Now, the issue, however, is that sclerosis it's not a very well-defined term, okay, and its usage here actually creates a few issues, and we'll just discuss that. So, the literal definition of sclerosis is just hardening. Systemic sclerosis is systemic hardening. Okay, fibrosis refers to the deposition of collagen in the extracellular matrix, and hyalinosis refers to the deposition of an amorphous material in the extracellular matrix. Now, what is my issue with this? Now, the issue is that you can't infer hardening of a structure without applying force and then deforming it. And obviously, that is not what you're doing under a microscope. Okay. Then the other thing is that with fibrosis, collagen again can only be demonstrated using special stains. Just by looking at it under the microscope, you can't be sure it is collagen. Okay. And hyalinosis is essentially meant to, create a deja vu, a feeling of deja vu regarding, the appearance of hyaline cartilage that people often discuss in first year of medical school. Um, However, the approximation is actually quite inaccurate. It is not an exact copy of that. Okay, and additionally, if you're not a histopathologist, or you're not someone who routinely sees pathology under a microscope, it might not really ring a bell for you. Okay, it might land on deaf ears. Now, the clinical usage. Now, sclerosis. I like to use this. I like to use these clinically usable definitions. So essentially, it refers to a thickening of the vessel wall due to either deposition of collagen or due to hyalinosis or high deposition of amorphous hyaline protein deposits. Um, Fibrosis is due to deposition of collagen, but essentially it means that a fibrillary or branching pattern of eosinophilic material is being deposited in the extracellular matrix with some interspersed nuclei, and these nuclei actually represent the cells that are depositing these this collagen or these proteins. That means fibroblasts, fibrocytes, and myofibroblasts. Now, hyalinosis means the deposition of an amorphous eosinophilic material in the extracellular matrix, and therefore this implies a certain mechanism to the pathology that you see. So, sclerosis could either mean fibrosis or hyalinosis. Fibrosis means there's deposition of collagen in the extracellular matrix by any cell, but it also could mean a decrease in the breakdown of extracellular matrix collagen. And finally, hyalinosis implies that there is hyperfiltration of serum proteins, which implies that there is obviously hyperfiltration only when there is increased hydrostatic pressure within the glomerulus. So it implies that there is intraglomerular hypertension. Okay. Okay. Now coming to our findings. This was the schematic of the normal glomerulus that I discussed. Now I'm going to replace it with the collapsing FSGS variant. Now, what you can see here is that the podocytes have actually left the basement membrane and have moved into the glomerular space. Okay, Because of that, because the podocytes provide structural integrity to the glomerular tuft, the capillary tufts have actually collapsed in on themselves, and that is what it means to have a collapsing variant of FSGS. Now, we can highlight the basement membrane using Jones stain, that is your silver stain. And I do this because I want to show that the podocyte has separated from the basement membrane of the capillary tuft of the glomerular vas membrane. So what you can see here is in this diagram or in this photo, the basement membrane can be highlighted like this. Okay, but there is a lot of a lot of cells almost foamy in terms of their cytoplasm that are proliferating within the Bowman space. Okay, and you can see that at least here in this area, the lumens of many of the capillaries are actually gone because they have collapsed. Okay, they have collapsed because the podocytes that were holding on to them have left, and we've discussed why this happens in the discussion on the mechanisms and clinical features of nephrotic syndrome. That is a previous discussion. If you this doesn't make sense to you, please go back to that discussion and have a look at it. So both the yellow cell as well as those foamy cells within the glomerular space represent your podocytes, which are occupying the Bowman's place that are not attached to the basement membrane underlying. Okay. Now, actually, FSGS is classified morphologically using a classification system that was called the Columbia classification, and this was originally published in 2004. And this is how the classification system works. Okay, so even if one of the glomeruli that you see under the microscope shows a collapse of even one glomerular tuft, okay, one single glomerulus, one single glomerular tuft, or it shows overlying podocyte hypertrophy. Actually, not and or both. It shows both this collapse and proliferation of overlying podocyte of podocytes. Then if that is true, then the patient has a collapsing variant of glomerular sclerosis. Now, see again, it's not 50% of the glomeruli, it's not 50% of the involved glomeruli. Okay, it's just one single glomerulus showing both of these features. Now, if both of these things are not there, okay, then what we do is we assess for the presence of one of three variants: the perihilar variant, the hypercellular variant, and the tip variant. Now, what is the definition of these? Again, these variants must satisfy the being classified as FSGS, focal segmental glomerular sclerosis. But after that, one single glomerulus can show what I'm about to say, and then that they get classified as that. So, uh, they have focal and segmental involvement, and at least one glomerulus is showing the following features. So, in case of perihilar variant, among the glomeruli with segmental lesions, perihilar hyalinosis must involve more than 50% of the such glomeruli. So the definition is hyalinosis, not sclerosis, hyalinosis. So it is specifically hyalinosis causing sclerosis that must be present in 50% of the glomeruli. So it's actually even one glomerulus only applies to these two. Okay, it's not here. Okay. Now, second is when you have hypercellular variant, you need increased endocapillary hypercellularity. That means within the capillary, there must be increased number of nuclei or implying increased number of cells, not outside. So it's not in the mesangium, it's not in the Bowman space. It is in the or overlying the parietal podocytes. It's within the capillary. Okay. Now, in the tip variant, you need one single segmental lesion involving the tip domain. So the tip domain is, if this is your glomerulus, the outer 25% is what we call the tip. So the outer 25% of the glomerulus should be affected towards the tubule. And so to say that is the outer two-thirds to outer 25%, one-fourth, you need to be able to identify the tubular, the proximal origin of the proximal convoluted tubule from the glomerulus. Okay. Now, there are some other features that may be there. So, in case of perihilar, hyalinosis is an absolute necessity. Okay, sclerosis may or may not be there. Okay. Now, in hypercellular variant, sometimes the endothelial cells that are there proliferating within the endocapillary lumen, they have a foamy cytoplasm. So, they are called foam cells, and they may show karyorrhexis or death or damage and of their to their cell, their nuclei, and therefore the extravasation of nuclear material into the extracellular space. The tip variant has no such optional features. Now, you cannot have a perihilar variant if there is either hypercellular variant or tip variant. and we'll see why that is the case just subsequently. You cannot have hypercellular variant if there is a tip variant, and you cannot have tip variant if there is perihilar sclerosis. So the thing is, perihilar sclerosis is not enough to diagnose of the perihilar variant. You need hyalinosis, but if there is sclerosis, it cannot be tip variant. Okay, and you'll understand why this is mechanistically and why this becomes relevant just now. Now, if all are no, we call that FSGS not otherwise specified, and that is actually the most common form of histological FSGS that one encounters if you are a histopathologist or a nephrologist. Okay, so the perihilar variant, as you can see here, one segment of the glomerular tuft is affected, of the glomerulus is affected, and there is hyalinosis at the hilum. So that is why it is a perihilar variant. So that is very clear. Okay, there is no tip involvement, so therefore it is definitely a perihilar variant. Okay, and the capillary lumina are open, so it is not a hypercellular variant. Okay, so that's very clear. This is a perihilar variant. Now this here again there is segmental involvement. Okay, but in addition to that, what you see is that within the capillary lumina there is a problem. There is no tip involvement, but the lumina are actually occluded here. Okay, and then finally in the tip variant, what we find is that it is the distal to 25% of the glomerular cross section that is affected, and it's actually extending into the proximal convoluted tubule. So obviously we have to be in such to say it is the tip variant, be able to identify the tubular pole. Okay, fine. So the tip is affected, that is a tip lesion. Okay, and there is no sclerosis at the hilum, and this is a very important distinction. Okay, fine. So hyalinosis at the hilum is actually not an issue, so you can have that, is fine. Okay. Now, before we talk about the FSGS morphological variants, we need to review the pathomechanisms, and this makes the morphological variants and their clinical correlations quite intuitive. So, what was the pathophysiology? We realized that once there is some loss of some renal glomeruli, there is decreased perfusion of the macula densa of those partially damaged nephrons. Okay, that causes release of renin, and that secondarily causes RAS activation. Now, the other thing is that there is activation of the intraglomerular short feedback loop. Okay, and that results in opening of the afferent arteriole. Now, when the afferent arteriole is dilated, and because of RAS, when the efferent arteriole is constricted, what you have is essentially a dilated vessel here, the glomerular capillary bed here. Okay, and a constricted vessel here. So this increases the hydrostatic pressure within the glomerular capillary bed, and that results in hyperfiltration. Okay, so that is intraglomerular hypertension occurs. So what we saw that was that when there is this kind of intraglomerular hypertension, in response to this, there is podocyte hypertrophy. Okay, and this is what results in the morphological changes that we club together under the heading of focal segmental glomerulosclerosis. Okay, so the question essentially becomes that does this increase in glomerular pressure affect all portions of the glomerular capillary bed equally? So this would mean that FSGS like changes would affect all portions of the glomerular capillary bed throughout, and there would be no predilection for the hilum or the tip or something like that. So obviously the answer is no, and therefore the differences in the topography or the distribution of involvement of the glomerulus are to be expected. Okay, but uh, so what are the repeatable patterns? So there are obviously repeatable patterns. We'll try to understand why these repeatable patterns arise. Okay, and that will be the subsequent parts of the discussion. So now we are going to understand the mechanisms that work here. So this is a mechanistic derivation of how FSGS morphology appears. Now, what I've done is I've replaced one of the tufts with just the capillary that is passing through the tuft. So this is the capillary coming here and then going back. Okay, and you can see that that has a certain length. Okay, and now what we need to see is from the origin of the capillary here, rather I'll use white, from the origin of the capillary here till the tip of the capillary, how much of the pressure is lost. Okay, and this is given by an empirical formula called the Darcy-Weisbach equation. And what does the equation show? The amount of pressure loss is directly proportional to something known as the coefficient of friction. Obviously, that is a constant. I'm not going to go into that right now. Okay, the length of the tube. So that is the length from here till here. Okay, the velocity of flow, which because the flow is laminar in the capillary, we're going to take it as a constant, and inversely proportional to the diameter of the opening of the tube. So the diameter of this area. Okay. So it is directly proportional to the length and inversely proportional to the diameter. G here stands for the gravitational constant, that is the acceleration induced by gravity on Earth. So that's not really relevant at this scale, so we're not going to go into that. Okay, so this is what the equation says. Okay, so naturally the pressure is decreased maximum at the base of the capillary bed and decreases subsequently towards the apex of the capillary beds. And so I'm showing it as that green triangle. Okay, now not for a non-compressible fluid in at steady flow, area and times velocity is a constant. Okay, so that is obviously we know that from Bernoulli's equation and things like that. Uh, okay, so the afferent arteriole is now, there are two possible situations. There is a constricted afferent arteriole, okay, and there is a dilated afferent arteriole. Now, when would we have a constricted afferent arteriole? We'll just see when that happens. And say when you have decreased sodium delivery at the macula densa, you have a dilated afferent arteriole. Okay, so this is the normal situation. Okay, and this happens when there is decreased sodium delivery at macula densa, which is also what activates RAS, but this is the short interglomerular short feedback loop. Okay, so what will happen? Now see, the diameter is higher and the velocity of flow is lower. Okay, so if the diameter increases and the velocity decreases, what will end up happening is that the pressure loss will be less. Okay, so if the pressure loss is less, what does that imply? That means that the pressure is going to be transmitted for a longer distance within the tube. So this is what the pressure loss looks like. Okay, here the pressure decreases much more rapidly, and almost by the distal disjunction between the distal proximal 2/3 and the distal 1/3, the pressure is almost zero. Okay, whereas here in this particular case, when the afferent arteriole is dilated, the pressure is actually getting transmitted quite significantly ahead. Okay, now yeah, so here what happens is that the head loss here is much higher, and therefore the tip of the glomerulus is spared from intraglomerular hypotension. Okay, head loss is the pressure loss that happens. That is why we call it HF. Okay, head loss is much lower in case of the dilated afferent arteriole, so the tip of the glomerulus is not spared from intraglomerular hypertension. Okay, so yeah. Okay, so this is what happens in the perihilar variant, and this is what happens in the tip variant. So what does essentially the presence of the perihilar variant mean? It means that the afferent arteriole is constricted, or it is not capable of dilating normally as it would have. Okay, and that implies that there is more structural damage. Okay, whereas if there is a tip variant, it means that the proximal most part of the afferent arteriole is actually capable of dilating, which means that the glomerular capillary bed is actually reasonably healthy structurally. It is just a temporary rise in the pressures that have resulted in this. Okay, now FSG is not otherwise specified is essentially just an extension of your perihilar capillary variant involving the entire glomerulus. Okay, okay. Now, like I just discussed, what determines the afferent arterial diameter? What determines it is the basically the amount of sodium delivery that is occurring at the macula densa. So as you can see, actually in specific neurons known as that have the your that are present at the corticomedullary junction, the thick ascending loop of Henle, that would be this loop, passes in between the afferent arteriole and the efferent arteriole. So this is the afferent arteriole and this is the efferent arteriole. Okay, and as it does so, it is able to control the diameter of the afferent arteriole, and by whereas acted control the diameter of the efferent arteriole. So what we're interested in is actually the diameter of the afferent arteriole. So what I'm going to just discuss right now is the diameter of the afferent arteriole, the mechanisms that control that. I'm not going to go into how the mesangial cell controls the last for now. Okay, so this is a thick ascending loop of Henle. You've got your sodium potassium 2 chloride channel here. You've got your basolateral chloride channel, which is leaking chloride into the extracellular space here. You got your basolateral sodium potassium sodium potassium ATP is pumped there, and you've got your apical ROM-K channel, which is leaking potassium into the lumen. So potassium is accumulating here, chloride is accumulating here. So there is positive charge here, there is negative charge here. Okay. Now, the sodium potassium 2 chloride transporter actually inhibits the expression of the eNOS, that is the endothelial nitric oxide synthase, or actually this is, the inducible nitric oxide synthesis, INOS. Okay. So your nitric oxide synthesis, therefore it inhibits the production of nitric oxide. Now, so if there is adequate sodium delivery distally, nitric oxide production will be low. Okay. Whereas if sodium delivery here at this point decreases, then what will end up happening is this inhibition decreases. So inhibition decreases, nitric oxide is produced. Nitric oxide then diffuses, because it is so anatomically close to the efferent arteriole, diffuses into the efferent arteriole, and the smooth muscles that are present around the efferent arteriole, they have your enzyme cyclic guanyl cyclase, which is expressed in the cytoplasm, that converts your GTP into cyclic GMP, and that activates a specific protein kinase called protein kinase G, which inhibits actin myosin interactions. Okay, so this is meant to show the actin myosin chains interacting with each other. So when that happens, they stop interacting with each other, and therefore the vessel dilates. Okay, so distal sodium delivery, the higher it is, the more constricted the afferent arteriole will be, and the lower it is, the more dilated the afferent arteriole will be. So I hope that is clear. Now, let's just see the morphologies of these three variants. This is your perihilar variant of FSGS. Okay, so now we'll go ahead and talk about the actual morphologies of these variants. So we've already seen that there is a segmental involvement of this glomerulus, and there is some hyaline deposition or hyalinosis at the base of the tuft, that is at the hilum of the tuft. So this is the perihilar variant. So histologically, actually, this is what it looks like. Okay, so this is obviously Jones stain, that is a silver staining has been done. Okay, you can actually see the basement membranes. The black colored structures are the basement membranes, and what you find is that this is the hilum. Okay, so as you can see, the hyalinosis is present at the hilum. Capillary lumina in the sclerotic part of the lesion are open, as I can highlight here, and finally there is no lesion involving the tip. Actually, I cannot really identify the tip, so I really can't say. So there is no tip lesion. Okay, now this is the hypercellular variant. So as we've just discussed, the lumina endocapillary proliferation resulting in loss of lumens here. So what does that look like under the microscope? Okay, so let's see the lesion. So here what you can see is that the capillary lumina in the sclerotic lesion are closed. You can't really see any capillary lumen here. Maybe this is one capillary lumen. Now I have used this image is slightly different in color because the trichrome stain has been used, and I'm not going to go into details of that right now. But essentially, collagen takes up a blue stain on trichrome. So all of this blue is collagen. Okay, so this was supposed to be a capillary lumen. Within the capillary, you see what you find, these foamy cells. Okay, that are occluding the capillary completely. There is no tip lesion. Again, I really can't comment on that per se because I can't find the proximal convoluted tubule, but I just presume that it is not there. And there is some degree of perihilar hyalinosis present. Okay, but that would be here. Okay, but or here, for example. Okay, but that's okay. We don't really mind perihilar hyalinosis. Okay. Now these are the foam cells. Okay, I hope that is clear. Okay. Now you also see some degree of overlying podocyte hypertrophy. Okay, but there is a visceral podocyte hypertrophy, but that is this reddish skull lesion here. But importantly, this hypertrophy is not associated with the collapse of the underlying glomerulus. So this is not the for collapsing variant. Okay. Now the tip variant. So as you can see, that was the tip variant on morphology. Now this is again something known as PAS staining or periodic acid shift staining that tends to it tends to highlight the glomerular or the parietal wall of the glomerulus more, so that you can see it here. Okay, and also the basement membranes quite well. So you can see the basement membranes are of the basement of the what is it called? The capillaries are very well are very well demarcated. Now, as you can see, this is also the proximal convoluted tubular opening. So that is the tubular pole. Uh, and inside the tubular pole, you can see actually there are some proliferating cells extending into it. So the visceral and parietal podocytes are proliferating, and they're extending into the proximal convoluted tubule at the tubular pole. So this is what we call the tip variant. Okay, not the hypercellular variant. This is the tip variant. Okay, this is the tip variant. Okay, so you can also see that there's a little bit of hyalinosis at the hilum. So this is the hilum, but again, this is not sclerosis. So this is still the tip variant. Okay. Now, what we've discussed till now is one, we've discussed what are the histological morphologies of the three types of entities that cause nephrotic syndrome. We learned to identify the histomorphology of glomerular membranous GN. We've learned to identify the histomorphology of minimal change disease, which is normal. Okay, we learned to identify the histomorphology of focal segmental glomerular nephropathy, and we've understood what that means. And we've understood what the collapsing variant looks like and why. We understood the physical and biological constraints that result in the perihilar variant, and then how that can progress to FSGS. Okay, as the afferent arterial contracts, or the is unable to dilate more and more. Okay, and finally, we've learned to identify the perihilar tip and hypercellular variants and differentiate them from each other based on the Columbia classification. So they should be pretty obvious. The diagnosis in this particular case is okay. So I'll divide it like this: half, only about slightly more than half or slightly less than half of the glomerulus is affected by this kind of pinkish material getting deposited, and within that pinkish material you've got some nuclei that are located. So this is what we would call fibrosis. Okay, and fibrosis is a type of sclerosis, as you just discussed. And at some points, this fibrosed area is actually attaching to the parietal podocyte layer of the glomerulus. So this is, I maybe I can call it focal segmental, but I would think this is more like diffuse glomerular sclerosis more than segmental glomerular sclerosis. Now, whether it is focal or not depends on how many glomeruli are affected, and I have not defined that here. Okay, so yeah, so that is the thing. So this entire area is your fibrosed area. So I would call this not focal, I would call it diffuse. Okay, so if you see this in SLE, we will call this diffuse. Okay, now let's look at what this is. So this is what we call nodular focal segmental glomerulosclerosis. Okay, so again, a part of the glomerulus is affected, only 50% is affected, but you find these nodules here. And these nodules are not hyaline. And why are they not hyaline? Because within the nodules or around the nodules, you've got your, nuclei of some cells located there, and they are also not located at the hilum. So this is a nodule formation within the extracellular matrix. Okay, and this characteristically occurs in your diabetes mellitus. Okay, so for in diabetes, when it occurs, we call them Kimmelson-Wilson nodules. And obviously, since it's me, I'm not going to just tell you that this happens in diabetes. We'll discuss why it happens. Okay, now this is not the only are classically described in diabetic kidney disease, but this is not the only cause. Okay, so what are the other causes of focal segmental glomerular sclerosis? That is nodular. Okay, it can also be the result of light chain deposition disease. Okay, so now light chain deposition disease is something that comes under the general heading of plasma cell dyscrasias and their related organ damage. And here right now, I'm just going to talk about the light chains and how what effect they have on when they get deposited in the glomerulus. So let's see what happens. Okay, so basically we've got a neoplasm, plasma cell neoplasm in the person that is producing specifically kappa free light chains. So free light chains are of two types, kappa and lambda. Okay, they are synthesized from different genes. That's why they call it kappa and lambda separately. Now, these patients are now producing they're producing a kappa chain that has got two structural abnormalities. Okay, now the light chains have got two regions. Okay, that is called the complementarity determining regions, or CDRs. And CDRs, there are three separate CDRs: CDR 1, 2, and 3. Okay, CDR 1 region in these molecules is extremely hydrophobic, and that results in it essentially causing the molecule to fold in upon itself. It is hydrophobic because some amino acids have been replaced that are normally there within the light chain, have been replaced by hydrophobic amino acids. Okay, amino acids that are not soluble in water. Now, CDR2 region in these light chains contains an exposed beta edge. Okay, and that is a beta pleated part of the chain, and that beta plated proteins are able to form polymers with each other. So that allows the polymerization or oligomerization of these kappa chains. Okay. So now under hydrostatic pressures, these kappa light chains can either get deposited in the mesangium, or they can get filtered into the Bowman space, and from there they get reabsorbed like all other proteins at the proximal convoluted tubules. Now, if that happens, the proximal convoluted tubules start to accumulate these abnormal kappa light chains, and that causes damage there, which causes Fanconi syndrome. Okay, which is basically proximal convoluted tubule specific dysfunction, and we'll get to that at a later date. If it gets deposited in the mesangium, this is what happens. These free light chains are endocytosed by mesangial cells using clathrin coated pits. So this is clathrin. These white lines are clathrin, a protein called clathrin. This coats parts of the membrane of the cell membrane and causes it to invaginate. Okay, and these free light chains then bind to a specific receptor or in within these clathrin coated pits, and that activates a downstream kinase known as the ribosomal somal S6 kinase. Okay, called the ribosomal S6 kinase. Okay, and that secondarily activates two transcription factors, one called NF kappa B, that would be this. Okay, and the other is called CFOS. Okay, and we'll be discussing this in great detail in immunology. So I'm not going into the molecular details, explaining the molecular details much here. But the transcription induced by NF kappa B and CFOS then induces the production of TGF. And TGF beta goes and activates its receptor, TGF beta receptor 1, which phosphorylates a family of proteins known as the SMATs. Okay, and that in turn causes even more, it causes the production of platelet derived growth factor, which also acts on the same platelet derived growth factor receptor expressing cells, expressed on these cells, and that induces folding up of the membranes of the mesangial cell, and that folding up of the membrane actually causes more production of clathrin coated pits, further increasing the endocytosis of free light chains. So this ends up becoming a self perpetuating positive feedback loop. Okay, and that keeps on causing more and more TGF beta signaling, and that TGF beta signaling eventually leads to a lot of collagen deposition, and that is what causes those nodules. Okay, because eventually those fibroblasts get converted into myofibroblasts and produce a lot of collagen, the extracellular matrix. So this is a very specific morphology that you see. It only happens here, and it happens in diabetic kidney disease. So why could that happen? Why would there be this kind of morphological overlap? So as you can see, the same entire process is happening. This is extremely analogous to the type of signaling that is induced by advanced glycation end products in patients who have very high blood glucose levels. Okay. And that happens in diabetes. So now this TGF beta as well as the platelet derived growth factor, TGF beta and platelet derived growth factor together have certain effects. Okay. So they have two very important effects other than for the positive feedback that I just described. So they cause one, they decrease the expression of matrix metalloproteinase type 7. Okay, which degrades an extracellular protein known as tenacin C. And tenacin C actually links collagen, different types of collagen, and prevents TGF beta signaling. Now, they also increase the expression of collagen type 7. So it's easy to remember MMP7, that is matrix metalloproteinase type 7, and collagen type 7. And that results in more collagen type 7 production, resulting in nodular sclerosis. So this same signaling, not this part, but everything distal to that happens also in diabetic kidney disease, and that is why you get Kimmel-Steen-Wilson nodules in diabetic kidney disease, and as well as in light chain deposition disease. We'll be discussing the other morphological findings that might happen with immunoglobulin deposition in kidney diseases. in subsequent lectures. But for now, I think light chain deposition disease should suffice. So this brings me to the end of this discussion. And so thank you for watching, and I'll see you next time.